I'm calling this meeting to order. Welcome to meeting number 9 of the House of Commons Standing Committee on National Defence. Bienvenue et bonjour tout le monde.
Welcome, everybody.
Taking place in a hybrid format pursuant to the House Order of September 23rd, 2020. The proceedings will be made available during the House of Commons website. So you are aware the webcast will always show the person speaking rather than the entirety of the committee. All right, so our meeting today will be twofold, and I wish to welcome our 3 witnesses today. Nora Spinks, President and Chief Executive Officer of the Vanier Institute of the Family. And from the Department of National Defence, Colonel Helen L. Wright, Director of Mental Health, Health Services, Group Headquarters of the Canadian Armed Forces, and Lieutenant Colonel Suzanne Bailey, National Practice Leader, Social Work, and Mental Health Training. Now, did you give an order? They're going to do their opening remarks in that order? Yes, okay. All right, so then I would like to welcome Nora Spinks to the floor for her opening statements, please.
Good afternoon. Thank you, Karen. Thank you for the opportunity to provide testimony today. I would like to acknowledge that our meeting is being held on the traditional unceded territory of the Algonquin Anishinaabe people and pay my respects to Indigenous elders past, present, and emerging. I would also like to acknowledge and express my gratitude and appreciation for all of you here today who have served or are serving this country. Thank you for your service. And to your families, thank them for their support and their sacrifice. It is an honor to appear today with my fellow panelists, people I admire, people that I respect, and I look forward to hearing their testimony. I am here today as the President and CEO of the Vanier Institute of the Family. The Institute is a research and education organization dedicated to understanding families, family life, and family experiences. Our ultimate goal is to optimize family well-being in Canada. Our founder, General the Right Honorable Georges Vanier, and his wife, the Honorable Pauline, understood the strength and importance of family. They understood that the military member was not apart from, but rather an integral part of a family. They knew the impact that family had on operational readiness. General Vanier served in both World Wars. He suffered injuries, among them losing his leg in battle. He understood the importance of mental health. He understood the impact of military service and that impact on both the service member and on the rest of his family. As we think about military mental health, it's important to recognize that mental health is not simply the absence of mental illness. Mental health is a state of being, not just a diagnosis. Mental health is fluid. Mental health is not about conditions, problems, and crises. Mental health, like physical health, requires conscious, deliberate attention. Like physical health, managing one's mental health includes prevention, early intervention, and individual calibration. Managing one's mental health requires self-care, access to information and resources, and sometimes to professional care. Managing one's mental health requires support from managers, colleagues, and coworkers, and it requires a strong personal circle of support. For most people, that personal circle of support starts with family. When we think of military mental health and supporting members to effectively manage their mental health, we need to see them as part of a family and part of a community. We need to define family broadly. Family is more than spouse and children. Family includes parents and grandparents, siblings, and ex-partners. Family is connections. Family may be biological, circumstantial, or consciously chosen. Family is dynamic, continuously evolving, and constantly adapting. Family, in fact, is the most adaptable institution in our society, and no two families are alike. To ensure CAF members achieve success, to ensure that they get the help they need when they need it, and not just when have reached a point of crisis, we and D&D, the country and the community, need to see family as a whole. We can do that with 3 straightforward strategic supports. 1, systemic supports, which includes framing and managing mental health as a key skill, recognizing and including family as key members of the wellness team, and educating and training for mental health competency, both at the individual and family level. 2, administrative supports. We need to create a culture where help seeking is seen as a strength and not a weakness, and providing access to services within military and in the broader community. And 3rd, professional supports. We need to use a family lens when developing communication strategies and treatment plans. We need to treat the whole family. We need to acknowledge that individual well-being affects and is affected by family well-being. So in conclusion, if we frame managing one's mental health as a core competency, if we focus on the whole person, including their circle of support, if we focus on the importance of social connections, and if we focus on honoring, respecting, and supporting military members and their families, and frame help as a tool for success, then together we will be able to optimize the mental health of military members, strengthen families, and create a culture of individual and family well-being within the military and other workplaces, and be a model for other workplaces across Canada and around the world. I look forward to our conversation.
All right.
Thanks,
Thank you very much, Madame Spinks. And I'd like to hand it over to Colonel Wright now, please.
Thank you very much, Madam Chair and members of the Standing Committee on National Defence. It's a real privilege to be here today with my colleague, Lieutenant Colonel Suzanne Bailey, and to have the opportunity to discuss mental health in the Canadian Armed Forces. My name is Colonel Helen Wright. I'm a family medicine physician with a background in research and occupational medicine, and I'm currently the Director of Mental Health within Canadian Forces Health Services. My team is responsible for the professional, technical, and sort of clinical lead guidance and policy for Canadian Forces mental health services and psychosocial services. I'm pleased to have at my side, at least virtually today, Lieutenant Colonel Suzanne Bailey. She's the Senior Canadian Forces social worker, as well as the National Practice Leader for Social Work within Health Services. She has also, for the past decade, led the Road to Mental Readiness, known as R2MR, mental health training program, overseeing its development, delivery, and evaluation of mental health training in the Canadian Armed Forces personnel. Now, mental illness is experienced by 1 in 5 Canadians over their lifetime, and some estimates are even higher at 1 in 3. And so this extraordinary impact that mental health illnesses and injuries have on Canadians is also reflected in the Canadian Armed Forces. Our studies suggest that 1 in 6, or perhaps 7 of every regular force member experiences a new or perhaps ongoing mental health issue in any given year. We know that anxiety disorders are the most commonly diagnosed, followed by depressive disorders. Accordingly, the Canadian Armed Forces encourages members to raise concerns, seek appropriate help when needed. Efforts are ongoing to really engage and educate our members in order to reduce all types of barriers to care, as well as reducing stigma. CAF members have access to comprehensive evidence-based healthcare system. It's grounded in family medicine, but augmented by mental health and psychosocial services that are delivered by teams of people consisting of psychiatrists, psychologists, social workers.
Please excuse the interruption, Colonel Wright, but the interpreters are having a hard time. They're asking if you could lift up your microphone, and it might be enough to help them do this.
My apologies. My apologies. So sorry, I was just listing off that. Is that better? So our teams that can augment our family teams include psychiatrists, psychologists, mental health nurses, addiction counselors, chaplains, and many others, as well as an extensive cadre of mental health specialists, civilian mental health specialists that practice in the community who also see our Canadian Armed Forces members. But as we were just reminded, health is much more than just a matter of clinical health care. And particularly in a military context, health is a very complex concept involving a whole broad spectrum of factors. And so while excellence in healthcare is necessary, it is just one element in a comprehensive array of Department of National Defense efforts on wellness and health.
Thank you, Colonel Wright. Once I'm going to have to ask you to actually pick up the microphone little piece and actually bring it up closer to your mouth.
Okay, sorry about that. Is that better?
Yes, thank you.
So in Canadian Armed Forces, we're looking for a fully integrated approach for lifelong health for our members, which of course includes health promotion and all sorts of healthcare services and activities, and contributions from a number of different groups in the CAF, groups such as the chaplains, the morale and welfare, transition group, to name just a few. But it also includes engagement from the chain of command and our leaders, members' families, as of course we were also just reminded, and of course at the center, the members themselves. So I've alluded to this extensive array of supports and services and health promotion, but clearly I don't have time to introduce them in these short comments. But Colonel Bailey and I look forward to being able to tell you more some of these programs and respond to your questions on mental health in the Canadian Armed Forces.
Thank you very much, Colonel Wright. And Lieutenant Colonel Bailey, please.
Thank you, Madam Chair. I have no additional opening remarks in addition to what Colonel Wright has just presented. Thank you.
All right. Well, thank you very much, Colonel Bailey. All right. So then we will open the round of questions. And the first is Madame Gallant, please.
Thank you, Madam Chair. Now, this would be to Colonel Wright. At what point are CAF members either relieved from duty or relieved from use of their weapons and training when it comes to relating issues to someone in the forces about mental health? So they feel that they've got a problem, they come forth, but what many members fear is that they're going to be taken off duty or they're not going to be able to use the firearms, and that is and they don't want anyone to know that they have mental health issues because of the stigma, of course, but that is what prevents some from coming forth. They're afraid of losing everything they know about the military, their job. So what is the trigger point at which they can no longer do their job or they have their weapons taken away?
Madam Chair, thank you very much for that question. It really speaks to, it really speaks to some of the core important concepts, which one is that privacy and confidentiality, which we know is just so vital to maintain for our patients in order to make sure that we have reduced any kind of barrier on that front. But at the same time, we owe it to the member to protect their health from further injury or illness, as well as to protect their colleagues if the person is not ready to perform at their best in some very demanding circumstances. So we do have the system of imposing some limitations on members, but only when necessary. I can assure you that we do not take that lightly. And we do know that although we go to great efforts to make these limitations that we share with the members' chain of command, to put them in such a way that it does not reveal anything about the member's healthcare situation. However, a major limitation, like saying that a member cannot use weapons, is of course going to be something gets noticed. But as I said, we use it to protect the member, to protect their health, to protect their colleagues' health, and I suppose lastly, to make sure that we're ensuring that operations can continue in a safe way. So I can assure you that that balance is well understood, and we are always trying to make sure that we are using those limitations only when necessary.
So when a soldier is identified as having a mental health issue or family situation that makes them vulnerable to or predisposed to suicide, what does the Canadian Armed Forces do in terms of communicating that to their chain of command?
Madam Chair, also a great question. Because we have this extremely important responsibility to the member to keep things confidential and private. It again is that razor edge of making sure that we are looking after the member. The first priority is to make sure that the member is well, or as well as can be expected, and getting the supports that they need. But as I said, also in that context of operations and making sure everyone else is safe and well supported as well. So it would be very unusual for us to approach a chain of command and talk about someone being suicidal. We would do that only in the most extreme circumstances where we really felt that someone's life or a colleague of that person's was in immediate danger. Generally speaking, we would talk to them about the employment limitations and of schedules for management of that person, but without revealing details of their illness or injury.
Report on suicide mortality in the Canadian Armed Forces showed post-traumatic stress disorder was a factor in the deaths of more than 33% of the cases. What additional supports and follow-ups are given to soldiers identified as suffering from PTSD while serving and also after release?
Madam Chair, so supports for all mental health injuries, although of course PTSD is an important one for many of our members. I don't know that singling out PTSD specifically, that there are special things we do for PTSD specifically that we wouldn't do for every other mental health injury, I guess is what I'm driving at, that we would do everything we can for every illness or injury. But for PTSD, we have a number of, we think of our mental health care on 3 pillars, if you will. So one is that we understand everything that we can about that illness in our population. The second is that we educate both the member, their families, and broadly in the community to understand illness and injury. And then the last pillar there is to care for that member. So for someone with, as an example, suffering from PTSD, we would make sure that they were, of course, getting the right care, the best clinical evidence-based care that we possibly could, make sure that they're getting all the supports that they can. We have peer supports through programs like OSIS, for instance, where you can get a formal peer support. So I think that it's definitely a multi-pronged effort to make sure that we are doing everything we can to understand the situation, support that member and their community, as well as, of course, that last element of clinical care.
Thank you very much, Monsieur Robia.
Mr. Robia, morning. Thank you for being here today. This subject is very important for me because I relate to it directly. My nephew, a member of the Canadian Armed Forces, attempted suicide recently. And this is why, although all the subjects we discuss here are important, this is particularly close to my heart. So could you talk to us about the impact of mental illness for the members of the Canadian Armed Forces, and especially the impact on their families?
Madam Chair, thank you very much for the question. I'd like to pass it to Lieutenant Colonel Suzanne Bailey, our social work expert, to maybe discuss some of those impacts on our members.
Thank you, ma'am, and Madam Chair. So from Statistics Canada, epidemiological studies that were done on Canadian Armed Forces members in 2002 and 2013, We know that Canadian Armed Forces members are impacted by mental illness and mental injuries at relatively the same rates as our Canadian general population counterparts, with a couple of exceptions. We do know that our rates of depression within the Canadian Forces have been consistently higher than the general population since at least 2002. And then the 2013 survey indicated that our rates of post-traumatic stress disorder, while they can't be compared to the Canadian general population because the same survey instruments were not used, we do know that our rates of PTSD have increased between 2002 and 2013, likely with some of that increase being due to a decade of combat in Afghanistan. And so we know that Canadian Armed Forces members are affected by other mental illnesses as well, such as anxiety disorder, panic disorder, and alcohol abuse. And so obviously we can expect that these impact not only the members themselves, but also their families. So the consistent numbers indicate that in any 1 year, about 16.5% of Canadian Armed Forces members can be expected to meet the criteria for at least one mental illness. So this will affect how they perceive themselves, how they perceive others, how they interact with their families. So a large part of my role in the last several years has been, first of all, making sure that we have services and supports in place for those who do reach out for care. So we have over 450 mental health clinicians in 31 different clinics. We have 37 clinics across the country, but 31 of those have specialized mental health care. So we have more than 450 mental health professionals offering multidisciplinary evidence-based care to support those members. And we also...
Je m'excuse de vous interrompre.
I'm sorry to interrupt you, but I do have several questions and not too much time. So what is the existing level of support for families of the Canadian Armed Forces, people that are suffering from a mental illness?
Thank you for the question, Madam Chair. So for the families, Canadian Forces Health Services does not have a direct mandate to deliver medical care or mental health care to families. However, we can provide care to the families in support of that member. But there are also a significant amount of services available for families through Canadian Forces Morale and Welfare Services. And in the last decade, they have established clinical social work services that are available in over 30 military family resource centers across Canada to be able to support those family members of the CAF members who are impacted by mental health. There's also a 24/7 family information line that is staffed by bilingual mental health clinicians that is available to families. And the Canadian Forces Member Assistance Program is also a 24/7 bilingual telephone service similar to many employee assistance programs that is available to offer crisis intervention, but also to provide referrals to both military members and their families in their local community to get the help and support that they need.
Are these treatments still available when the members of the CAF come back to civilian life?
Thank you for that question. Once military members transition out of the Canadian Forces and become veterans, their care is taken care of by their family physician, the civilian healthcare system, as well as Veterans Affairs Canada. Now, we do have a memorandum of understanding between our clinics and Veterans Affairs operational stress injury clinics to provide care for each other's personnel in areas where we may not have coverage. But there is a transition process that takes place through case management to ensure that there is follow-up care in place once the member leaves the Canadian Armed Forces and becomes a veteran.
Okay, Monsieur Bruxelles.
Mr. Brunel Duceppe, please go ahead. Thank you, Madam Chair. I would like to thank our witnesses for being here with us today, especially Colonel Wright and Lieutenant Colonel Bailey for your service in the Canadian Armed Forces. And thank you, Madam Spinks, for your commitment. I'll begin with questions for the Lieutenant Colonel and the Colonel. A 2020 study on veterans and active members of the Canadian Forces that was published in the Journal of Military Family Health says that women have a higher rate of PTSD and chronic pain compared to their male counterparts. My question, how does the Canadian Armed Forces respond to the specific needs of are there differences based on sex, gender? How do you manage that?
Question. Indeed. Oh, my apologies. Indeed, we know that there are differences in how women and men present with a mental illness, exactly as was described in the question. But our way of, our model of treating our members is very much an individual model. We tailor the treatment to the person, to their illness, to their wants, even things like their family situation and perhaps their occupation. So I think that really is how it's not so much that we have a difference in our approach for men, women, or any of the other identity factors that we find amongst our population, but it really is an individual approach to that person and tailoring the treatment to them.
So there is no real difference based on gender and as far as providing health services. So I presume you do take into account whether the patient is male or female in some aspects.
Wait, okay.
Madam Chair, yes, indeed. Of course, we take into account those kind of factors, but all the factors, right? A person is much more than just their gender or their sex, of course. And so that's what I was trying to illustrate about an individual patient approach, right? Everything about that person, their illness, their experience of that illness. We know, especially in mental health, there are a lot of different ways to treat any given illness, and it is often a bit of a trial and error with any individual patient to find what works best for them. And as I said, it is the whole person, the holistic person, and their whole circumstance that we are looking at and treating as best we can. But of course, that would include gender and sex. Excuse me. Yeah.
Okay.
Well, thank you, Colonel. I would ask a question now to Ms. Spinks. In 2016, a study published a snapshot of military and veteran families in Canada. That was a document, and they said 15% of military families that stay on bases across Canada have access to resource centers for military families. These centers offer programs and services, support services for mental health. But the families of soldiers who are not living on these bases, do they have access to these resource centers for military families? And if not, where can these families obtain similar quality of services?
Vous êtes sur mute, Madame Spinks.
Yes.
Madam Spinks, you unmute.
We always said if we all received $1 for every time somebody said, hey, you're on mute, or sorry, I was on mute since March, we would never have to fundraise again. So thank you for that question. As you mentioned, more families now are living off base than on base, and that is a reality that's taken place over the last several decades, actually. And so now the vast majority are living off base, and their spouses or partners are more likely to be in the paid labor force. So what we're seeing in our research is that families are often seeking mental health services in their communities. So family physicians, community-based mental health programs, they're going to their faith leaders. They're going to sort of the natural place to get mental health services that you and I would go to. they are able to access the services on base, but they have to get there, and there's hours of operation, and if you're working in the paid labor force, it's sometimes hard to align with those services. So one of the things that we've done in our military veteran health initiative is to really focus on those community members that might be the first point of contact. So we've been working with our partners across the country to build military literacy, so that if a family member or a military member phones up an EAP or goes to their family physician or goes to their local mental health provider, that they are in fact aware enough of the language. So they know what a posting is, they know what the lifestyle is, they understand what it means to be part of a military family or be military connected. So trying to build the points of contact so that when a family member is concerned about the military member needing some kinds of supports, or if they themselves as a caregiver or a member of a circle of support need assistance, that they'll be able to access it when and where they need it. It's not a perfect system. There's still a lot of education and awareness to be done, but we have been able to reach all family physicians across the country. We've been able to reach early childhood educators. We've been able to reach pediatricians. We've been able to reach a variety of professionals that hopefully, if they are the first or one of the first points of contact, that a family can receive the care they need so that they can get the care quickly, so that there's less likelihood of cascade into crisis.
All right, merci beaucoup.
Thank you.
Blaney, please.
Thank you, Chair, and I would like to thank all of the witnesses here today for your important testimony. A special thank you, of course, to Colonel Wright and to Lieutenant Colonel Bailey for your service. I really appreciate you being here with us today. Mental health, as we all know, has a huge stigma across Canada. I do believe, though, that the stigma for military and other high-stress frontline workers, it's even higher because everybody looks to them to be the strong one in the middle of a crisis. I know that we are still losing, on average, more than one serving member per month to death by suicide. And I've also understand that the estimates are up to 10 times higher in the members who attempt. So I think this is such an important study because we have to make sure that in every step that we take, we're supporting our military in the best health mentally and physically as we possibly can. So I just, again, want to thank both of you for your service and also the work that you're doing on this important file. One of my questions is, I'm concerned about the idea of self-harm, and I know that in the National Defense Act, we have 98 bracket C, which is really based on self-harm as a deliberate avoidance of duty. And I'm very concerned that that is not the message that we want to send out to our military folks. I'm just wondering if there's any concerns that you have around having this kind of language in our National Defense Act when we're looking at opening up the doors and taking away stigma for people who are considering harming themselves. Colonel Wright, if I could start with you.
Thank you for the question, Madam Chair. What I can tell you here is that I have never heard a patient or a healthcare provider in our system express concerns about 98C or any language like it. And so my perception from my experience and the teams that I work with, the patients that I've worked with, we have not heard that message that it is one, as you have outlined in your question, we are working very hard, and it will be an ongoing effort to continue to reduce barriers. But this is not one that I am hearing is
yes,
a barrier.
Colonel Wright, could I ask you to reposition your microphone, please? Thank you.
I am so sorry.
Well, thank you for answering that. I still have concerns. I think language really matters, and there are things that are invisible, and they're right there in front of us, and people see them. And I know that we had a mother that was a witness in another study who came forward, and that was her concern after losing her son. We need to make sure that language is clear. I'm just wondering about what the current state of mental health resources are in the CAF. We've heard previously that there are reports of sometimes long waiting lists. And now with COVID, we know the demands that could only be increasing. We heard testimony not too long ago from military folks that went in to help with the long-term care centers and saw the crisis and how stressful that was on them. So I'm just wondering if we could hear a little bit about the resources and if there's any extra demands because of COVID, and if there's any recommendations we could provide.
Madam Chair, thank you for the question. It's difficult for me to describe our supports because they really are so many that it's sort of outside this medium to be able to explain them all. But I will maybe address part of your question, at least with respect to the concerns about COVID-19 and the potential increased demand and how we're handling that. Initially in COVID-19, in fact, our demand went down, and we were seeing similar things. Some of our civilian colleagues were saying the same thing. Some of our military partners were reporting the same thing. And it was a little difficult to understand exactly why that was happening, but we were all, including the patients, I think, all pivoting right in that suddenly new circumstance. And we brought in things like virtual care. We had been working on virtual care before COVID-19, but there is no question that the circumstances and context of COVID-19 has really pushed us forward with our virtual care. And so that is an example where we are really trying to make sure that we are making the mental health care as well as the psychosocial supports as accessible as possible, even in this new context. It is truly as simple as picking up the phone and having your mental health interaction with your care provider, perhaps by phone. Now, interestingly, I think this does introduce different barriers depending on who you are and what your circumstances might be, because now if you're having your mental health interaction from your home, and there are perhaps other people living in your home, it may be difficult to find a truly private place to be able to have a phone conversation or a Zoom conversation or something like that. So interestingly, although I think on balance, things like telehealth and virtual care in response to COVID-19 and making sure that we're meeting those needs is helping most of our clients, it may not actually be helping everyone, which is why we are still offering in-person, much more on the pre-COVID-19 model as well.
Thank you. I only have 8 seconds, so I will let them
Sorry.
go. Thank you, Chair. No, that's okay. Thank you for your answer.
Thank you very much. Okay, Mr. Dowdle, please.
Thank you, Madam Chair, and I want to thank as well our presenters today, witnesses. Thank you for your presentations and thank you for your service. I guess my first question goes probably to Colonel Wright, I would think. And I was just wondering, as we know, in 2017, we're extremely pleased that we had a joint suicide strategy prevention. And we have numbers. In 2018, we had 15 deaths. 2019, we had 20. And I can tell you on a personal note, my riding, I represent base board. And so any of those suicides certainly affect the military family here on the base, but off the base as well, as they're often involved in the local hospitals as well. So it's a real touching time for us. But I'm just wondering if you have some numbers. We're at December 3rd or December 4th now, I guess. If you have some numbers for this year to see whether or not we are actually making some progress.
Madam Chair, that is really a super question because it allows me to talk about something that's I feel really is really important. So the first thing is I'm afraid that I'm not going to share the 2020 numbers with you today. Those numbers will absolutely be made public when we, at the end of the year. And we deliberately delay releasing some of that information because of some of the privacy concerns that we've already alluded to in other questions. We are such a small population, and although each and every suicide obviously is a tremendous impact on family and friends and colleagues, in the end, our numbers are quite small. And so we would expect variation from year to year in our small population in the numbers of suicides. And so for me, it is not about the number of suicide in any given year. That is not how, I don't think that's how we should look at whether our suicide prevention efforts are working, because we expect that fluctuation. And so it's not about chasing the number. Even if I was to tell you today that the numbers for 2020 were much better than in another year, or if they were much worse than another year, we would still do everything we could to prevent every suicide we could, although acknowledging that we cannot prevent or predict every single one. And so to me, I think it's important to take, oh, sorry, go ahead.
I just gonna say I agree with your comments that every year it's going to fluctuate, but I guess part of the reason why I'm asking is that you want to hopefully move forward in some way, and then it follows up to my next question, which is I know if you I've kind of delved in, it's kind of a subject close to my heart here. You know, since the study came, there was like 160 kind of new and existing actions that were supposed to take place, and I don't know how many of those 160 have been acted upon, but one of the ones when you delve into it was one that really kind of touched me, because I think it's most important when people are in their darkest moments, is that we need to have, and it actually stated on here that in one of the recommendations was to have a 24/7 crisis support line, whether you phone, text, or chat. And I know myself, I was really touched when another member of parliament, the member from Prince George, or Caribou Prince George, is bringing forward a number, a simple number, a 988 number, that at that time, no matter what, someone has someone to talk to. So I'm just wondering, do we implement a 24/7, or do we have anything that right now presently with the military? Because I think our government coming to Christmas, this is the time more than ever that we need to reach out and make sure we have those supports. So the simple question, I guess, would be, have we acted on that recommendation, number one? And number two, if not, do you believe that it's probably a good idea that we might save a life?
Madam Chair, thank you for the question. I think that you are absolutely right about the importance of people having somewhere to turn when things go, if things are dark for them, in addition to all the, I keep alluding to this array of services that we have. But of course, they don't all speak to every single person. However, with respect to your specific question on a call line, as Lieutenant Colonel Bailey mentioned, we already have a 24/7 bilingual, completely confidential line in the CIFMAP program, the Canadian Forces Members Assistance Program, and that does include a crisis line style of service.
So there's somebody on the line 24 hours a day, and it's quite common that all the military would have an easy access to get to that number.
Yes, sir. It's a 24/7 bilingual, at all times. And yes, it's a number that we publicize as broadly and as widely as we possibly can. Members and their families can use it. And there's also a family information line, and it too is a 24/7 bilingual and includes a crisis line component as well as other components. They're not purely crisis lines, but that is one of the services they can offer.
Thank you. And over the 160
Thank you very much. I'm sorry, I'm going to have to ask Mr. Spengeman, please.
Madam Chair, thank you very much, Colonel Wright, Lieutenant Colonel Bailey. Thank you for being with us. Thank you for your service. And through you, I would also like to thank the women and men that serve under your command for their service. Great to have you, Ms. Spinks, and thank you for your important work. Madam Chair, I served in a war and conflict zone for just under 7 years as a civilian UN official stationed in Baghdad. And during the latter part of that time, in a fairly short window, our team lost 2 colleagues to suicide. One of them was a serving U.S. Armed Forces officer who was attached to the United Nations mission as a liaison officer to the coalition forces. And the other was a UN civilian security and protection officer who was regularly exposed to potentially hostile scenarios in Greater Baghdad. My question, I guess, is around the idea of access. So we've heard a lot of testimony about the programs that are in place, the funding that backs these programs, the importance of these programs. In your assessment, are there still barriers to access that go beyond or are different than the stigma itself and are simply a function of the fact that the person in question has suffered an injury that may prevent her or him from even having the motivation to seek help? Access, in my assessment at the moment, is still very much a demand-based option. There is very rigid screening, mandatory screening upon entry into the Canadian Forces, including psychological screening. Are we looking at access as too much of a demand-based option? Should there be greater emphasis on, in whatever rational and reasonable way, pushing the programs more into the lap of somebody who may have an injury?
Madam Chair, I think a number of excellent, pardon me, I think a number of excellent points made in that question. The first was your allusion to whether there are indeed still barriers to care that are perhaps different than the one that often seems to come to the top of the list in stigma. And I think unquestionably we are still, our system is not perfect. There are still barriers to care. And I think you're right. A lot of it is a demand still based on the member, recognizing that they need help. However, we are trying to combat that. And so education of our members so that they can recognize when they might need help is extremely important. And for that, I actually will pass the question to Lieutenant Colonel Bailey because some of the education that she and her team do, I think, is really critical to that.
Thank you, ma'am, and thank you for the question. And stigma and other barriers to care is very interesting because we often think that stigma is the primary barrier to people seeking mental health care, when in fact many studies over the past 2 decades, not only in the Canadian Forces, but in other populations, show that the number one barrier to seeking mental health care is that the individual does not perceive that they have a need for care. So that was one of the reasons we developed the Road to Mental Readiness program, which has the 4-color mental health continuum model to increase mental health literacy and hopefully earlier recognition of distress and earlier access to care. Now, we do know that there are other barriers to care that exist, some of them related to stigma, worrying about what others may think of me, how my leadership may perceive me, how others may treat me. For the most part, those the data regarding those stigma-related barriers is fairly encouraging. The interesting part of that is that we find that once people are impacted by a mental illness or a mental health injury, their perception of those barriers tends to increase significantly, and those barriers become much more important. Some of the other barriers are more structural barriers. People feeling that they don't have time, they may not know where to access. So we spend a fair amount of time in our education programs talking about how one might overcome or challenge some of those particular barriers to care. And the other aspect is negative attitudes toward care seeking, which we also spend a fair amount of time in our education program talking about, specifically around letting people know that mental health treatment is effective, that it's evidence-based, and what mental health treatment might look like.
Colonel Bailey, thank you very much. If in the remaining 30 seconds, maybe just broach a question that perhaps there's some time to elaborate on. Those Canadian Forces members who've served in a combat setting or directly or indirectly, are we moving closer to the recognition of a potential presumption of injury, or are we still quite a ways away from that?
Sorry, I don't think that, Madam Chair, we're not presuming injury because I think there is still enough variety in the experience that would be a step too far. But to be honest, I haven't reviewed the literature on that. But what we do is screen people. So, and I know time is short here, but I think that what is key is that when people come back from deployments or these demanding circumstances, we have a screening program to try to pick up those folks that may be suffering and do not yet realize that they are, to try to get them into services sooner.
Thank you. Thank you very much, Madam Chair.
Thank you very much. On to Monsieur Brunel-Duceppe.
Monsieur Brunel-Duceppe, go ahead. Thank you, Madam Chair. The Canadian Armed Forces and Veterans of Canada, they have published their joint strategy of suicide prevention in 2017. So it's a joint strategy. According to the Minister of Defense, there are 15 suicides in 2018, and this number increased to 20 in 2019. So in your opinion, what was the efficiency of this joint strategy? And if possible, how could you measure the effectiveness of that strategy?
Madam Chair, as I mentioned already, I think one of the ways that we should not measure effectiveness is looking at the fluctuations in our numbers from year to year. Looking at the fluctuations in our numbers from year to year. I think that is perhaps over many years, we might be able to see trends, but certainly not year to year. But what we have done with that suicide prevention strategy that you mentioned, for the Canadian Armed Forces, it was turned into the Suicide Prevention Action Plan, which had 95 different action items. And so your question about how do we measure progress on the Suicide Prevention Action Plan, it is being tracked very carefully. We report on the different action items quarterly, for instance, but how we measure each of those, because you can imagine that in those 95 items, there's a huge variety of things. And so some of them, something like the road to mental readiness, it might be measured on how many programs we've adapted to customized circumstances and occupations, or how many people we have trained. But in another item, it might be something like the clinician's handbook into preventing suicide. That one was tracked by whether we completed the task, which we did. So I think that following how we're doing is dependent upon what that action might be. But I would make a statement overall as to how we recognize if we're doing better is the reports we get back from members through surveys and things about their ability to recognize when they might need help, recognize how they would help themselves or how they would help another person. I think it's those kinds of broad concepts, which is how we know that our action plan is making a difference.
Merci beaucoup.
Thank you.
Thank you, Madam Chair. If I could come to you, Ms. Spinks. I know that when untreated mental health issues have a huge impact on families, and we've heard that some organizations that are working with our military families are really struggling to manage this. I'm also hearing stories of loved ones, families, members who notice that the person serving in their family is struggling. And I think that's interesting because as Lieutenant Colonel Bailey just said earlier, often the challenge is not knowing yourself that you need that support. So I'm just wondering if you could talk about any understanding that you have of the impacts on the family when somebody has a mental health issue who's not acknowledging it, and what families do to try to support that member.
Thank you for your question. Madam Chair, this is a really important line of inquiry because families are often the very first people to identify that something's off. They will see it long before the individual person may, in terms of self-assessment or self-awareness. They'll begin to see little things that just don't seem right and may then begin to say to their loved one, I'm starting to see, you seem to be a little short these days, and begin to help them self-assess. And that is a skill that we can train. That is something that we can teach families to do, to observe, to interact, to intervene, to provide some of that support that will encourage help-seeking behaviors. And then, if not, then advocate on their behalf. The challenge is that oftentimes without that training or that support, the tension builds within the household and the family falls apart. And we need to pay attention to those caregivers and those people within the circle of support. So that's why I was saying earlier that we need to think about families not just as spouses, because often the spouse is the first one to notice and the first one to leave. And so that means that the sort of the second tier or the second circle in that circle of support are parents. And then oftentimes they'll be the ones who will be attempting to support that person with help-seeking behaviors. And they may not have received the information about the 1-800 number and the helplines, and they start Googling and they start panicking because they're not in the loop to begin with. And so when we use a family lens and we see the family as a key component of the healthcare team in terms of identifying what needs to be done, identifying when things are going a little off, being right there to begin that early identification, early intervention, and we support them, the entire circle of support, then that makes a difference. The organizational culture recognizing that families are there as a tool and not a burden or a dependent, then I think that will have a huge impact on the value and the success and the impact of the programs and services that are offered. The programs that are offered to both members and families are amazing. The well thought out, evidence-based, the people who deliver those services are doing so with the very best of intentions. And not always are families aware of what's available, and not always, particularly if there is no spouse or that spouse is no longer available, that they're able to access or fully leverage those programs.
All right. Thank you very much. Mr. Benson, please.
Thank you, Madam Chair, and thank you to all the witnesses for appearing today and for your valuable testimony. Colonel Wright, we've heard some testimony, and we know that in past cases, when a CAF member dies by suicide, that the family has great difficulty in getting information from the military. In some cases, it takes years to find out some of the details of what happened. Can you talk a little bit about what the military can do to maybe break down some of those barriers and shorten the time frame so that these loved ones, because in a way they're suffering in mental health issues too when they can't get this information, and then we're sort of compounding the problem and making it worse. So how could we help them get more information?
Madam Chair, again, some excellent points made there. And I think that the military has come a long way in recognizing that this is an important component of what we do when we do investigations into suicide, and or when we're looking at supporting, say, the colleagues or the teams that were around the person who has died from suicide, that we remember to include the family as a core group that also needs to be supported. So I do think that we're coming along, we've come a long way there. And I know that part of our effort, one of the things that my group does is the medical investigation, if you will, into deaths from suicide, and that includes inviting members of the family, and not necessarily just that spouse, but parents and other family members as well, to be part of that process of the investigation, and then making sure that they are aware of what we're aware of. Now, of course, I'm speaking of the medical investigation, but I know similar efforts are made for the boards of inquiry as well, to make sure that as we learn more about the event and the circumstances around it, that we are making sure that we're feeding that information back. But I would caution that there is often also, though, a competing interest in making sure we are maintaining the members' confidentiality. And so sometimes our hands are tied based on the members' paperwork, but that's the best way we know what the member intended. And so if the member has stated in paperwork that so one person or so-and-so person is someone is their next of kin, then we are obliged to work through that person, which may not always be the people that feel that they should be getting information. So I know that we still have challenges there, but as you can see, it is caught based on the very best of intentions to make sure we're doing what the member would have wanted based on the information that we have. But I certainly recognize how challenging and how painful that would be for other family members.
Well, thank you. The Canadian Forces Ombudsman had a recommendation that the families meet with the commanding officer to discuss the events leading up to maybe the events of surrounding the suicide. Is that something that's routine now and is happening all the time, or has that been implemented?
Madam Chair, I'm afraid I don't have visibility on that, so I cannot. I can't comment on that either way. I would imagine that it is happening in most cases, but I'm afraid I can't speak to it.
Okay, thank you. In the road to I think it was the Road to Mental Health. There was 15 objectives, and one of them talked about suicide contagion and minimizing suicide contagion and the communication surrounding that so that it was handled properly. Can you talk a little bit about that concept of suicide contagion and what leadership is doing to minimize that from happening?
Madam Chair, really important question. We are torn between wanting to recognize that in many cases, part of the picture when someone dies of suicide may be their military experiences, and recognizing that person and their contributions, of course. However, we do know from, this is mostly civilian literature, but also some military studies from the United States, that there is this contagion that if it's people read about a death by suicide that seems to glorify it or seems to make it seem as though it has additional benefits either for them and their reputation, but perhaps for their families, right? If you that can in fact be an additional inducement to people to choose death by suicide rather than perhaps seeking supports and help for the way they're feeling and their other struggles, which of course is the way we would prefer people to go. So it's this difficult balance between recognizing the person and their contributions to the military and their struggles, and yet at the same time not wanting to portray it as an attractive option to other people, because as I said, we want them to choose different options. But it is known that it can happen, and so it's a real phenomenon that we must avoid.
Excellent. Well, thank you.
Thank you very much. Monsieur Robillard, s'il vous plaît.
Mr. Robillard, please.
Sont les conditions?
What are some of the conditions in terms of mental health to allow a member of the Canadian Armed Forces? What mental state should they be in before they are sent on a mission?
Madam Chair, that's an interesting question. I'm going to pass that to Lieutenant Colonel Bailey with her experience in doing pre-deployment and as well as during and post-deployment mental health training.
Thank you for the question. So prior to any deployment, a military member will undergo a couple of types of screenings. One would be a psychosocial screening. They're encouraged to include their family in that, and that the objective of that is to see if there are any personal or family factors that may interfere with them being able to complete their mission. It's a fairly standardized 30-minute screening, and the intent is to make sure that we're not putting the member at any additional risk by sending them on a particular mission. They also go through a similar medical screening with their primary care provider to make sure that there are no underlying health conditions that may be put at risk by them going on the screening. Prior to the deployment, we also provide Road to Mental Readiness pre-deployment training, which is tailored to the mission and the environment into which they're going, to make sure that they are aware of the resources available to them, that they also are able to recognize early indicators of distress, and we spend some time making sure that they can use some of the skills and tools within the training to manage the particular demands of that mission that they're going on.
Les conditions afin de...
The conditions for deployment, are they the same every time for each deployment?
Thank you for the question. Each deployment is evaluated before a mission is initiated. So the conditions can vary greatly depending on if it is a combat mission, a humanitarian mission, a peacekeeping mission, or even sometimes a training mission. So a number of different assessments are done to make sure that all of the stakeholders involved know what the conditions of each mission are, so that all of the training and preparation for the members proceeding on each particular mission can be adapted to the particular environment they're going into.
Could you speak about the treatments following a diagnosis on of a DSO or operational stress disorder? Any treatments?
Madam Chair, I think that, again, in the context of this medium and the sort of time constraints we have, I think that I will fall back on the reminder that our treatments are, of course, they're evidence-based. We try to stay right at the leading edge of guidelines on managing different mental health conditions, including operational stress-related disorders. But in the end, any given treatment plan will be customized or tailored, if you will, to that patient, to their experiences, to their the types of techniques that seem to work for them. So there isn't just one given recipe that works for everyone. And that's one of our challenges in mental health, especially, is finding the right combination of things that works for any given individual.
Madame Présidente,
Madam Chair, do I still have any time left? The question is for Ms. Spinks. As CEO of the Vanier Family Institute, how does the pandemic influence the lives of Canadian families, and more specifically, the families of the Canadian Armed Forces and the first respondents?
Madam Chair, we've been conducting polls with families week over week since March. The impacts of COVID on families and family life has been quite dramatic, not all tragic. A lot of families are actually doing quite well, but it does lead us to a number of observations. The first is that every system in our communities, in our society, every system, healthcare system, justice system, child welfare system, etc., every single one of those systems, including the family system, has had its strengths magnified, amplified, and intensified as a result of COVID, and equally their weaknesses. So families that were struggling are likely struggling harder. Those that were doing well are likely still doing well. The ones in the middle, there are many that are still adapting, adjusting, and finding ways to support each other and to work together. Workplaces all across the country, and the military is no different in this case, have had to adjust and modify how, where, and when work gets done. So the big issue here is the degree to which disruption has impacted a household. And the greater the disruption, the greater the likelihood is that individual family members will feel that they've lost their sense of agency, their sense of control, their sense of autonomy. And when families lose that, often stress levels go up. So I think when we're looking at COVID, it really is everything that was pre-COVID and then some. And so we need to monitor and keep an eye on how families are doing month over month and into next year, and learn from every one of those experiences. And we will continue to do that with all families across Canada, including military and veteran families. And we have a survey in the field looking at how veteran families are managing and adapting, and we would be happy to share that the results of that with this committee and the Veterans Committee as well.
You're next.
aux autres membres de...
Thank you, and I'll let the other members ask their questions.
Thank you so much, Mr. Bazan.
Thank you, Madam Chair. I was expecting the NDP or the block had to go before me. So I do want to thank our witnesses for appearing. I believe that the service that you're providing to our military members, along with their families, is second to none. And that I know that we're always trying to do better, but with the unpredictability of suicide, it's always going to be a challenge. Now, Colonel Wright, my colleague, Mr. Dowdle, had requested the numbers for 2020 as number of suicides that had occurred. We are going to be publishing a report very early on in the new year on suicide prevention in the Canadian Armed Forces. Would you be able to provide us with those numbers as quickly as possible so that we can include them in our report when it is published in February? So we'll need that data as soon as you have it, which is hopefully within the first couple of days of January.
Madam Chair, of course, the information will be made public. I can't tell you exactly when. There are other factors to do with public affairs and when these things are released, but I absolutely understand the interest in knowing that number, although I would take the opportunity to just say again that I think that our numbers, given that they fluctuate from year to year, is not necessarily the way that we should be evaluating our system.
No, and I appreciate that, but we do already have the data from years previous. There's a lot of people that always want to look at, the numbers and how that relates over time to what we're dealing with, and there has been, as we mentioned, a number of programs that have been rolled out over the time, and so Road to Mental Readiness is one of those programs that I think has helped with self-assessment, has helped troops assess each other and to look for any indications of deterioration of mental health. Ms. Spinks, would you be able to talk to the fact on military families? Should military families also be offered Road to Mental Readiness to help with that self-assessment for themselves as well as for their loved ones who are serving?
Thank you for your question. I think the Road to Mental Readiness program is an excellent example of translating a very complex issue and coming up with evidence-based programs that are accessible and available. And yes, military families have had access. And in fact, Lieutenant Colonel Suzanne Bailey and I have presented the Road to Mental Readiness program to corporate Canada even. So this is a program that's been adopted by the Canadian Mental Health Commission as well as one of their signature programs. So it's a very useful program. I also think that it's really important to recognize that families are resilient, including military families are resilient until they're not. And sometimes there's a lead up to it, to a tipping point. And what we want to do is we want to help people identify when they're at the suicide ideation stage. So when they're thinking about it, but haven't necessarily done anything about it, we want to let them know that they can seek help at that point. If they've taken it a bit further and they've actually developed a plan, then we need to make sure that they know that they can reach out for help, and on down the steps and stages. People don't tend to go from being well one day and being suicidal the next. So we want to create as many opportunities as possible to support them and their family members from along every stage, and the interventions are different depending on what stage they're at and what stage the family's at. So I think what we need to do is to make sure that there's a broad base of support in communities, in neighborhoods, as well as within the confines of the military family and the military operations, and make sure that people are aware, including those that aren't normally included, like parents, for example, that don't get access to the information, that don't get included in the awareness initiatives, and may or may not be aware of programs like Road to Mental Readiness.
No, I think the more that we can do, especially when it comes down to treatment on mental health, as often as possible, if we can treat the entire family, I think we'd see a lot more success in reducing in preventing suicide and reducing the number of suicides.
And the evidence bears that out. You're absolutely right.
Okay, and so one of the concerns I've always had is, and this is for health services in general, is our reservists are often located in communities where we don't have a base. We may not, have an operational stress injury clinic. We may not have military psychologists, social workers, and psychiatrists readily available. They may be sitting, in Thunder Bay, Ontario, and the closest facility and closest base is Winnipeg, an 8-hour drive. So how do we better provide service on mental health to our reservists who may not be able to get to the Canadian Armed Forces Health Services Group?
Madam Chair, I think two main prongs to attack that particular problem. The first is to remind you that we do extensively use mental health providers in the civilian community. So a civilian psychiatrist who sees military patients, for instance. And so although a person may find themselves a distance away from a supporting military base and one of our military clinics, that does not mean that they don't necessarily get health care. Many of our reservists, depending on the type of contract, the type of work they do, their medical care is grounded in the civilian healthcare system anyway. But I am very
from them over the years, Colonel, that often the people that they have access to in the civilian side do not understand operational stress injuries in particular and how to treat them.
No, I recognize that. You're absolutely right about that. So I was just going to say, but one of the things that I'm very excited about, many of us are excited about, is this shift, this almost seismic shift in use of telehealth and virtual health that COVID-19 has helped us push forward. And I think that is going to be the way forward for some of these folks in more remote places where we can now use other options so that they can see a provider that is familiar with the military, is perhaps more familiar with operational stress injuries, and speaks their official language of choice, which is another important aspect for our members when they're distributed around the country. So I'm really, as I said, excited and optimistic that that's going to help us move that forward.
Thank you.
Thank you very much. Mr. Baker, please.
Thank you very much, Madam Chair. And thank you to all of you for being here today to speak with us about this really important topic. My first question is to Ms. Spinks, and maybe just for the sake of folks who aren't as familiar with the issues we've been talking about, or for my constituents who might be watching this at home, could you share a little bit about what is the impact on families when someone is struggling with mental health challenges, who's a serving member of the armed forces?
Thank you for that question. Families play a very important role in first identifying that there may be a problem. Families play a very important role in searching through the various information to sort of nudge their family member to supports that might be most effective. They play a really important role as advocates if their family member is not receiving the care that they need. And they're often a really important part of the team in between treatments. So they're the ones who are there every day, day and night, and remind people to apply certain techniques or remind them of the therapies that they've been receiving, remind them to take their medication. So families have a very deep and important role. When there is somebody in crisis, when they need more emergency intervention, where they may have harmed themselves or they may have put themselves at serious risk, the families then are often sort of cut out of the circle of support. Once it becomes hospitalization or it becomes intensive treatment. And what we need to make sure is that they continue to be recognized as an important player in the team, because when that person leaves the crisis treatment, they're going to go back to that family. And that family, stop and start doesn't work as effectively as when the two are integrated and treated together. The other thing we need to recognize is that often caregivers are experiencing stress themselves, and they need caregiver relief and caregiver support as well. And benefits and programs directly targeting caregivers is absolutely critical in the continuum of care and the suite of programs and services that we need to be considering very carefully. Because without them, then the cascade happens very quickly into more dire situations or circumstances quite often. So really important to keep them through the entire process and give them the support that they need as well.
Thank you for that. That's helpful. I guess then to follow up on that, then, what are the things that need to be done, given the family plays such an important role in supporting the member of the forces through this? What needs to be done and what more could be done beyond what's being done today to ensure that they're being engaged appropriately to provide that support that you're talking about that is so important?
Well, I think the first thing is to treat the whole family unit as the core, so that it's not the military member and their family, but it's the military member's family that needs to be at the center of any intervention, any treatment. And it sounds like it's a little thing, but it's actually a big thing. I also think that it's really important to recognize that family is diverse and family is ever changing. And so it's not like you can say you've, informed the family, check, you're done. It's that it needs to be done on a continuous basis, and engagement of family members in the conversations and in the dialogue is critically important. And the research is really clear that when there is success, it's usually because there's a strong circle of support and a strong family connections and really healthy relationships. When there isn't, the same applies in the negative. So I think when we look at the ways in which we want to move forward and we want to plan, family lens, critically important. Family engagement, an absolute definite. Recognizing the diversity of families, critical. And when we think about the ways in which we can leverage those relationships and nurture those relationships, is to recognize them, honor them, acknowledge them, and engage them right early on. And I know that there are a number of programs in place right now that are attempting to do that. We need to celebrate the situations and circumstances that have been successful. So not only do we want to spend time studying the cases that have not ended well, but we need to spend a lot of time researching when we get it right, and how can we take those learnings and translate those across. We do have a wonderful generational opportunity now because we're talking more about mental health, and we start with children when they're toddlers. Share your feelings, tell us how you're feeling, use your words, how can we help you, what kind of help can you need? Kids are now in age 2 and 3 being taught how to ask for help. That's going to give us this huge opportunity going forward because the foundation is already laid. Very different from previous generations that were raised with suck it up, shake it off, move on, don't let it bother you, don't let them see you cry. A lot harder to engage in talking about mental health. So I think we're creating a perfect storm here with really good evidence-based programs, really good acknowledgement of what works, and a commitment from people like you around this table who want to get it right. And I think we're creating a perfect storm to go forward with really positive results. And I think, we can measure impact by also recognizing how people are thinking, feeling, as well as what they're doing. So thinking, feeling, and doing. And it's not just the end results, but it's the impact of their behavior and their thoughts and their feelings as a result of even knowing that these programs are available, even if they don't need them, just knowing they're there is sometimes program enough. And so I think we can't underestimate the power of families and family connections in this space.
All right. Thank you very much, Monsieur Brunel.
Mr. Brunel Duceppe, please. Thank you, Madam Chair. It's very interesting, everything we're hearing today. I thank you to the three witnesses. We experienced something quite unique this summer, the laser operation. This is not something that when soldiers go to the armed forces or the reserves, they don't expect that. They don't expect to live that. We're talking about combat operations and life-saving operations during natural catastrophes. But what we had this summer, nobody had it since the Spanish flu. So we are going through a very difficult situation. And I don't know, maybe you're not able to answer because it's fairly recent, but maybe you have an answer for us. Are you aware if there are soldiers, and I would like to thank the Canadian Armed Forces for the laser operation. That's appreciated by everyone, notwithstanding political parties. I just wondered if soldiers or reservists participated in the laser operation that had mental trauma following this operation. Are you able to answer that question? Maybe Colonel Wright.
An excellent question about how this unusual operation may have affected our people. As it happens, Lieutenant Colonel Bailey she's really the expert on how we tried to prepare folks for this different circumstance before they went in, support them while they were there, and then do post-deployment support. But I think perhaps your question, the answer to your question is that we are doing a study of all the folks that were involved in Operation Laser as a follow-up to try to find out exactly how it did affect them, right? So the things we put in place to try to prepare them and support them were based on what we assumed would help or what we thought would help. But we are doing a fairly extensive study with a number of different departments within DND contributing to do something that is a little bit unprecedented to try to find out what actually did happen. Many of our partner militaries, for instance, are following very closely to see what we learn. I don't have results yet to announce, but it's going to be very interesting to follow what we learn, and then of course make changes to how we prepare people for the future, even if we don't do anything exactly the same as Op Laser, but to take those lessons into whatever the future might hold for us.
All right, thank you very much.
I would be curious to read that study. Maybe Lieutenant Colonel Bailey can say how exactly do you prepare soldiers based on mental health, taking that into account when you have such a unique operation taking place on our territory?
Madam Chair, thank you for the question. That is, in fact, an interesting question because, as you have identified, this was different from anything that Canadian Armed Forces members had been asked to do before. And there were obviously some unique challenges, how to deploy people within a pandemic environment and then into a community that may be the same community that some of the people lived in. And it was a very different patient population. As you know, our Canadian Armed Forces members are between the ages of 17 and 60. And those would be the types of patients that our care providers would be used to seeing. And we're a fairly healthy population because we're screened. We do a lot of physical training. And so a fair amount of training went in, not just mental health training, but there were about, I think, 8 to 10 different training modules preparing the members to go in and provide a very different type of care to a different population. And then the role that I specifically had with my team was to look at how do we mentally prepare them to deal with some of the demands of caring for those patients, but also taking care of themselves and looking out for their buddies and the teams they were working with throughout what at the time was an unknown duration of a tasking. And so a lot of focus was put on making sure that they were rotating through different tasks, they weren't working overly long hours, but also teaching them, as well as their leadership, how to support each other within the small teams that they were working in, as well as depending on the mental health support resources that we had put in place for them.
All right. Thank you very much. Madame Blaney, please.
Merci.
I see Mrs. Spinks. Did you have something you wanted to add to that?
I just want to mention one of the things that we've been studying about COVID is the fact that what makes it particularly unique is that as people are responding, whether it's healthcare or emergency services or military members, remember that they are going through it exactly the same time. So unlike going into a humanitarian situation where you're going into a post-hurricane, you weren't living the hurricane. These members were and still are living with COVID. They're worried about their kids, they're worried about their families. They might have gone to school in the neighborhood, as Lieutenant Colonel Bailey said, you know, they know these neighborhoods, they know these communities. And the fact that they too were responding to COVID themselves and worried about their own families and worried about their own grandparents makes it doubly difficult. And it's something that we're really trying to understand, because we've done the best we can to support people in this situation. But as you said, this is very, very new. And it's the same with researchers. Researchers normally research something that they're not directly involved in. COVID's a different story. So it's a really complicated time, and we will be studying this for decades, and we will be living with the impact of this for 100 years. So thank you for that really important question.
All right. Thank you. Madame Blaney.
Well, thank you, Madam Chair. If I could come back to you again, Colonel Wright and Lieutenant Colonel Bailey, just a question about the road to mental readiness. I was very happy to see and understand that families also have access to this training. So I guess my question is a couple of things. The first thing is, Ms. Spinks talked earlier about it's not always just the family, it's that circle of support that you have. So I'm just wondering if the circle of support and whatever that family system may look like for an individual member, if that is included, and if people who they identify as their support folks are welcome to join this. And then the other part of the question is, how does DND evaluate the results of the program and sort of take that opportunity to improve or increase some of the best practices? That would be so helpful. Thank you.
Madam Chair, I'm going to pass the question straight over to Lieutenant Colonel Bailey, who is the expert.
All right, thank you, Madam Chair. So a two-part question. So with the Road to Mental Readiness for Families, we make it available currently through the Military Family Resource Centers to whomever the member identifies as their family. But recognizing that not everybody can access the physical centers where they are, we are in fact in the final stages of developing a comprehensive online suite of training modules for families of Canadian Armed Forces members on a variety of topics related to how can we help both CAF members and their families manage the various demands of service. And this will be available in both languages, and it will be openly available across Canada as well. There will be no password required. And the nice thing about that is it will also be available to the families of Canadian first responders, many of whom have received the Road to Mental Readiness through some of the partnerships that have already been identified. Getting on to the second part of the question regarding how do we evaluate the program. So we evaluate it through a number of different means. For the first 5 years, we had pre and post tests that we analyzed the data to see if we were seeing differences in stigma, attitudes, and knowledge regarding mental health. That information was very encouraging and showed that, in fact, we did see statistically significant improvements, even though some of the training is a fairly short time period. Let's say in basic training, they might receive 3 hours of training. We were still seeing very encouraging results. We also included questions in the Canadian Forces Mental Health Survey that Statistics Canada conducted that indicated that over 70% of Canadian Armed Forces members had received mental health training, and there were questions on whether they found it effective for dealing with daily stressors or sometimes more extreme stressors. So there's data available there. And we've inserted questions into other studies that have been done, looking at whether people use some of the training on deployment, whether they have increase their use of positive coping skills versus negative coping skills after receiving the training. And then we've just finished rebuilding our program logic model to identify additional outcomes that we can measure in the coming years. So we continue to look at innovative and creative ways to study it, not only what happens in the classroom, but how people are going to apply it in their day-to-day lives and how it might actually contribute to their ability to cope with the demands of daily life.
All right. Thank you very much. Mr. Bazan, please.
And Colonel Wright, you mentioned the crisis line that was being used both for military members and for military families. Would you be able to undertake and report back to the committee with the data on how often that those crisis lines are used?
Madam Chair, of course, we'd be happy to do that. I can just give you a quick thumbnail. I think it's over 4,000 different members and family members used the Canadian Forces Member Assistance Program in last year. And I think about 3,000 or a little over used the Family Information Line. But we would be happy to give you the
okay, I appreciate that. I assume that some of that might be domestic violence, people calling in for military police.
Absolutely. It's a broad spectrum. Yeah.
Okay, I know. I appreciate that. Now, in the CAF Suicide Prevention Action Plan, it lists 15 objectives, and number 7 reads, barriers to care such as stigma are eliminated. Since, so, you know, we want to make sure that we're eliminating as much stigma as possible. You've already mentioned that, you know, part of the culture within the Canadian Forces is nobody wants to ever, you know, be claimed that they're weak, and often mental health is, you know, the stigma is that if you're having mental health challenges, you're weak. So have there been enough changes happen? You know, what type of programs have you brought into place to change that culture?
Madam Chair, so absolutely, it is vital that we shift the culture. And I like to think that it has come along a fair ways, which isn't to suggest that we don't still have work to do, for sure. But perhaps I will pass this one over to Lieutenant Colonel Bailey as well to talk about, because it isn't just programs like Road to Mental Readiness, although it is a fantastic wellness, it is a fantastic program, but it also teaches about literacy about mental health so that members understand it better. And that is part of our method of trying to break down some of these, if I may be permitted to say, old school ideas about how people should handle these things. But it is
I think over
the only program.
Over the last decade, we have started to see that, you know, it really is, you know, buddy checks, you know, want to make sure how everybody's feeling. And people are now, the troops are prepared to talk about, you know, their feelings and what they're going through and the challenges that they have in their day-to-day lives. And I think that goes back to the RTMR. You mentioned, before we turn it back to Lieutenant Colonel Bailey, one of the questions was about self-harm and the impact of Section 98C of the National Defence Act. And you said that you are not aware of how that had created any problems to increase suicide or prevent suicide. So would you say 98C is agnostic on the issue of mental health, or do you say it's a deterrence if it's not something that is a barrier? She's frozen. Are they all frozen? Maybe Colonel Bailey might be able to.
All right, I will do my best to answer that. It appears that Colonel Wright's feed is frozen. The interesting thing about 98C is, from my knowledge, I've been in the CAF over 34 years. I would be inclined to think that most Canadian Armed Forces personnel are not even aware of Section 98C of the National Defence Act. That being said, I know there have been discussions for many years about changing that. I don't see, you know, what possible benefit it could provide. But for the most part, I think when Canadian Armed Forces members are impacted by mental health and are struggling and trying to identify solutions to their issues, I would not think that this particular issue is something that comes to the forefront when they're struggling in their darkest times.
Did you hear, Colonel Bailey? So 98C, in your opinion, choking on here, doesn't add to the overall stigma within the Canadian Armed Forces, and you're saying that since nobody even is aware of it, and we know that it's rarely used because hardly ever do you still hear somebody actually going out and literally shooting themselves in the foot to avoid service. So, and the only time it has been used, or in some cases, was for those that actually tried to commit suicide. So the elimination of that section of the Act shouldn't create any problems.
I wouldn't think so. And from the numerous studies we've had on stigma and other barriers to care, it is not one that has registered, with significant numbers.
Thank you.
Right, thank you very much. Madame Brière, s'il vous plaît.
Madame Brière, please. Thank you, Madam Chair. I'd like to thank our three witnesses. Thank you for your service. Especially, we understand from our discussion this afternoon, you're confirming that the needs in terms of mental health support and that there is a real need for that, and that you take this issue very seriously. My son is in the hostile regiment in Quebec. He took part in the laser operation, and in the pre-deployment training, it was clearly stated to him the services that he could rely on. And in Montreal, where he was deployed, there was a chaplain always ready with a wide open door to listen to him and take care of him. And following the operation, when he came back home, he received a call. He received emails just to check in on him post-deployment. So I would like to know, when Colonel Wright, when you mentioned in your opening statement an integrated approach, is that a concrete example of this integrated approach? And maybe you can offer some other examples.
You're on mute, I think. Sorry, Colonel Wright, we don't have your audio feed. Just stand by a minute. So what they're saying, sometimes the mic piece actually has an off-on button on it. And if you pick it up and move it closer, you might have mistakenly turned it off. So let's see. No, that's weird. Can you plug and unplug, please?
All right, how about now?
Now it works. Thank you very much.
Oh my goodness. The equivalent of a restart. So my apologies for the technical problem there. Where was I? Was saying about our integrated approach, and that yes, I think that the integration of our our prevention and health promotion methods were part of what we tried to do on Op Laser. An excellent healthcare system for those that are struggling and need help, of course, is important, but it is equally important, maybe more important, to have all these kind of preventions and supporting services in place. So the question was about another example other than Operation Laser, but I'm trying to think of something that's not operations based, because I think we do something very similar to what we did for Operation Laser on our other operations. As Lieutenant Colonel Bailey answered to another question, we screen people before they go, as well as in conjunction with their families to make sure that it's the right decision for them and the right time for them to go. We have supports in place for them while they are deployed. We do post-deployment screening to verify how folks are feeling when they come back, and to try to facilitate getting them into care if that is what is the right thing for them. But also we have a host of other psychosocial supports and educational things that we can also help direct people toward. I think that some of the other things that Lieutenant Colonel Bailey mentioned might also be relevant to the question about how we're integrating. So I know we keep coming back to Road to Mental Readiness, but it's a great example of how that is being integrated in throughout members' careers. So it is provided in basic training. It's provided in many of the other steps in a military member's career. So it's no longer, as it started out to be, something to support people on difficult deployments, and is becoming something that we are just integrating into everything they do, our members do, and helping make them stronger in a career, even if they never deploy. Which, of course, we absolutely have members who never have to put themselves in that situation, but we still put them in demanding jobs, and where things like managing their mental health, being proactive, is still just as important.
All right. Well, thank you very much. And that brings our session today to a close. I would really like to express my sincere thanks to our witnesses today. I think your testimony was absolutely foundational, and I think it will help us build an even stronger report going forward. I would ask the committee members to stay online. We have a little bit of discussion, but I'll allow our witnesses to leave us at this time. Thank you very much for your time today. We know it's precious, and we appreciate it very much. Take good care.
Thank you.
Merci.
Thank you, Madam Chair. Just want to have a quick discussion. We have 2 meetings left before our Christmas break, and I know that we are scheduled to have JAG and the head of psychiatry from the Canadian Armed Forces here on Monday. What are the plans for Friday? Is that because I know that we want to lay out kind of the objectives that we want to see covered in our reports to the analysts so they can be drafting. So are we doing that on Friday for both reports on COVID-19 as well as the mental health of the Canadian Armed Forces?
That's exactly, I think. So there's 2 ways of doing this. If we're sitting on Friday, we can do it as a committee. We can also do it secretarially. So I would expect both of those reports. What we were going to ask is by the 18th of December, if we don't end up with a full meeting on Friday, but by the 18th of December, any recommendations or input you have for either of those studies, make sure it's into us by the 18th of December. Is that good?
Okay, I agree with that. So can I make a suggestion then for Friday? Because we are writing the report on Canadian Armed Forces and COVID-19. Since we heard our witnesses, there has been some news, which is now that we have Operation Vector led by Major General Danny Fortin. So I think that it would only be in the best interest of our committee and having a valid report is that we actually have General Fortin back at committee here, along with General Christopher Coates, who's commander of CJOC, and he's going to be the force multiplier and making sure that all the logistics is taken care of in distribution of vaccines. This is something that is critical information for our citizens. Canadians want to know how and when we're going to get vaccines distributed. We also heard that there is this cybersecurity threat that has been on the cold supply chain and how that will impact on delivery. And even if you look at the policy directive from the CDS, he even has in there, make sure we prevent criminal and cyber attacks against the transportation. We've heard in the past on PPE where some have gotten stolen and diverted into other countries that were supposed to come to the United States and elsewhere. So I think we want to find out what is, even on the commercial logistics part of this, where there, my understanding is Pfizer, for example, is using United Airlines to deliver the vaccines to points of delivery in Canada. But will there be logistics officers on board? Is there going to be security personnel there, whether it's, special operation forces or military police? But, how are they going to prevent, the cyber and the criminal? And so I think it is worthwhile for us to have this meeting on Friday with Generals Fortin and Coates.
Madame Président.
Yes, Yves.
Madam Chair.
En français, bien sûr.
In French, I think we should take next Friday to really complete this. We haven't had enough people, witnesses, representing people who have lived these situations. They're easy to find. I know we are drawing towards the close, but if we want to have a full, complete study, I think we are going down the wrong track.
Maybe then we might need to take this to the steering committee. All right, we have two competing ideas of what to do with next Friday, so I think we'll put together a steering committee meeting. And okay, and yeah, we will do it at the steering committee, right? Well, I think, all right. But maybe it's better done at the steering committee. I mean, this is, when the committee goes forward, we won't want to be all on the same page. And this is something that we need to work out. So is this...
What about the other members? Maybe they have some opinion too.
Yes, but they can express their opinion at the steering committee. Okay, but, all right. No, that's true. That is true. Okay, go ahead then, Madame Blaney, and then Monsieur Brunel-Duceppe. A minute each, please.
Absolutely. I just want to say that I agree with Mr. Bazan. I think this is an important part of what's happening in the future around COVID-19. Canadians do need to know how they're going to be getting their vaccines. And of course, I know that Canadians trust the military, so it would be a good voice to hear on this issue. Thank you.
All right, Monsieur Brunel-Duceppe.
Mr. Brunel-Duceppe. It's fun that the NDP and Conservatives and the Bloc Québécois are all on the same page. I think the Liberals would also agree with Mr. Bazan. I think it's very important. We really don't have any choice but to go this way next Friday. But you're saying we'll decide at the subcommittee. That's fine. And I think it's a good decision we can take today, but it's up to you, Madam Chair, to make that decision. But I'm 100% in agreement with Mr. Bazan.
Take this to the steering committee because I'd like to have us all on the same page moving forward. So, yes, Madame Galante.
Okay, so I would like to suggest that maybe we have an extra meeting. There were outstanding questions, and we have questions about the distribution of the vaccine now. And we want to know the answers to these questions, in addition to Mr. Robillard's insistence that we have more. We could have an extra meeting, say, Wednesday before the break. Can we? Okay.
There won't. The problem is there won't be any parliamentary there won't be any parliamentary services like translation and stuff. So all those things have to be taken into account, but we will discuss it at the steering committee.
So can you clarify, Madam Chair? Do we still have the translation and the services?
We have to go and
18th?
look into, nothing is firm. So there might be a way to make it happen, but we cannot guarantee it. So we'll need to go and do some research.
I believe that parliamentary, like the upgrades that are being made to the virtual committee meetings and that are happening after December 19th, and that will lose those services for about 5 weeks. So,
but there are still restrictions in place once Parliament adjourns. And we don't know when Parliament's going to adjourn, but after it adjourns, there will be restrictions. So it's something we'll have to look into, and we can talk at the steering committee. Okay? Meeting adjourned.